Next, may I invite Dr. Apoorva? Yeah, she'll be talking about Trocar Follies in posterior persistent fetal vasculature. Dr. Apoorva is a consultant at MM Joshi Eye Institute in Hubli.
Something went wrong with my presentation and some desperate measures have been taken.
Right.
So
We have been seeing desperate measures since morning, so no issues. Can we have the presentation, please?
ये on किया है मैंने. Should I put it in a PPT or something? Direct video play नहीं कर सकते ना? कैसे? थोड़ा light off हो सकता है. Okay. So this is my one of the cases, the first of the cases of a series of cases of pediatric retinal detachments. This was the case. Case 1 is Trocar Follies. So this was a 5-year-old boy with a white reflex in the right eye noticed since 7 months, and it was increasing progressively. A right eye total cataract was diagnosed. A B scan was done, and what we felt on the B scan based on the history and the axial length of the eye, we felt it was an anteriorly and posteriorly closed funnel RD, and this was looking like some tractional membrane. So in all fairness, went in thinking it is a posteriorly closed funnel RD, removed the lens and put the trocar at infusion site at 2 to 2.5 mm, not very posterior. When I went inside, I was pleasantly surprised and also horrified at the same moment, because it was a PFV case, a posterior persistent fetal vasculature. So now we know the follies that can happen when we go in thinking it's a RD case, but it turns out to be a PFV case. So you can see the retina is almost, pristine. I'll just keep replaying because these are too short to write. So its retina is looking so good. There is this elongated ciliary processes with a centripetal pull. And this is when we have to be very careful of one particular anatomy of the retina in these cases. This is of course the stalk of the posterior persistent fetal vasculature. I trimmed it. Then this is what we expect, because whenever there is a centripetal pull of the ciliary processes in a case of PFV, we almost always expect a very anterior insertion of the retina at the ora. So now even 2.5 mm from the limbus is too further posterior for this case. So I have encountered an iatrogenic break posterior to this membrane. This is the PFV membrane also. This is the cyclodialysis cleft due to a traction. Not a cleft, a cyclodialysis. Now I had no choice but to excise this anterior flap, like you can see, because otherwise it would cause traction and cause PVR, anterior PVR, that too. Then now I found that the centripetal pull is obviously because of an anterior fibrous component of the persistent fetal vasculature. So all these cases, apart from having a posterior persistent fetal vasculature, also can have an anterior component which is also fibrosed, which causes centripetal pull of the ciliary body, cyclodialysis, anterior insertion of the retina, which causes the subsequent complications in this case. Now just see how difficult it was to trim this fibrous tissue. I'll just show you, this is the fibrous tissue, this one, and I'm trying to dissect it from the base. It was very difficult. You can see it is very stuck Now what I'm doing is I'm actually bimanually dissecting it from the base. This is what I had to do. And then I tried to trim this fibrous tissue using a cutter, which was in vain, because these tissues are very cloth-like. They don't. I even went in with a frag. You can see I'm gone in with a frag. Then I finally deliver it out through a limbal incision. So this was how tough it was to tackle. Then after PFCL air exchange settling the retina, I've lasered the large break. I've done an oil injection, but anybody can guess what happened to this eye. This eye went into very severe anterior PVR. This is a very early post-op picture. I'll just show you that picture. This is, I think, maybe 1 or 2 months. I have a picture at 6 months where under oil, there was a lot of PVR. So this image can be very confusing because this axial length was 21 mm, not too small. It was a unilateral leukocoria. What can happen in PFV is that it can have anterior insertion of the retina on the side of the centripetal pull of the ciliary processes. And the fibrous tissue can be extremely thick. The anterior part of the PFV can be extremely thick. And in my case, it didn't get trimmed by a cutter. A frag was tried, it didn't help. So I finally had to deliver it literally through a limbal incision. So because the anterior part of the retina is much more anterior compared to normal anatomy, there can be iatrogenic breaks because of trocar insertion itself. So if UBM can be used to plan in sclerotomy in all cases of pediatric retinal detachments when we don't know for sure whether or not it is a PFV, to locate the pars plana on the UBM is a good idea. You can even start limbally if we are not sure whether there is a PFV. I hope the video was comprehensive because it was very short. It's part of a much longer video, so I had to pause and show. Yeah, it's done. Yeah. Yeah. 1 second. You want the B scan or the entry?
When you are
When you
about to
made your
enter.
entry.
Okay. 1 second. Yeah, there.
Okay. So this patient had a cataract.
Yes.
So PFB anyways there are two predominant varieties. One is the posterior variety, one is the anterior variety. Well, you had the anterior PFB. So
And the posterior stalk also.
so that is always
That
there.
is always
so
there.
you have predominantly posterior. Then it would be have more traction on the posterior part, and then you have the
Yes.
anterior PFB, which is your type.
Yeah.
So in this case, I think you did fairly well. Fairly well in the sense what I want to say.
Anatomically.
Yeah, you are very lucky because even if you cut the stalk, they bleed sometimes very profusely. If you cut, and even when you are cutting this whole membrane, which you said that you're not able to, they start bleeding like hell. So the issue is that whenever you cut, you have to do extreme diathermy, and then only you can cut. Even if when you're cutting, I don't think you did the diathermy.
I did. I have not. There is some bleeding. You can see those
but
those points I
that is why
dithermized.
you are very lucky. Because
Yes,
it was just bleeding, didn't allow you to stop the surgery. You were able to
Right.
complete the surgery.
Right.
It's very, and I think the only take-home message that we can do is that if you are encountering such a case, before entering the trocar, UVM is not a practical solution to anything. So what you can do is once you had taken out the cataract, you could have just self-indented and then see, and then you could have put the
Exactly.
trocar at
Yes.
6 o'clock position
Yes.
or this. You could have just changed your position and then it would win. Because if you touch it, then the eye is gone. If
Yes.
you create a break, then it's gone.
Yes.
Apoorva, just a thought instead of doing that our regular trocar cannula thing, could we have done it the AC maintainer thing so that we could have avoided
Yes,
that injury?
absolutely.
It's a retrospective thought anyway. You have done
Absolutely.
it nicely.
Once you decompartmentalize the whole
Yes.
eye, you can just go for AC maintenance. So that
And indented, like he said, and seen just
you can
before.
put the right place where you want to enter the trocar.
And regarding that stock thing, na, you did correct that you did not try to avulse it. Otherwise, it would have been catastrophic sometimes. Even
No, never.
if you try to do it, sometimes in the diabetic retinopathy cases,
Correct.
we are successful in doing that, but here it is very dangerous.
Probably. When you have such a closed idea that it is, this is closed funnel RD. You know, that spinal level, it's like, see, it's not that I had any.
Close funnel RD, the color doctor is positive only, no?
Exactly.
So can that help to distinguish whether, I mean, depending on the arterial flow, because retina would also have some arterial flow, right?
What one of my radiology friends was saying, some other case we were discussing, that they do that prenatal USG, and if they are confused whether it is a congenital retinoblastoma or a PFV, they do a Doppler.
Yeah, that is what I'm saying.
So
Because
I think PFV has some values.
yeah, that is what I'm saying. They would have a predominant one arterial flow.
Yes.
While a retina would have a diffuse arterial flow. Something
Probably,
like that. I'm just guessing.
Probably.
Because there will be one stop, it will be coming, and then it could have.
So, see, looking at the B scan, would you have considered PFV?
No, we do get these pleasant surprises. I agree with you. At least two cases.
Not
The
pleasant.
problem what happens is like we don't do ultrasounds. We sometimes just see the reports, and that is what. And in that time we kind of think it's more of an RD. If we are doing our ultrasounds, sometimes we may pick it up as PFE and not RDs. Yeah.
That if you have a patient who had a bilateral RD, this picture, then I would have operated. But now we are thinking that a patient has a one eye, and one eye is absolutely normal, right? Other eye, we are thinking closed funnel RD. Will you enter this patient or not? Because you are thinking it's a closed funnel RD, no?
No, it's not.
Anterior
I will
posterior.
enter this case.
Anterior posterior closed.
No, I would I diagnose a PFE and then, like, if you were me, whatever. So would you have done what you did, what you advised me to do at the first go? Like, would you go limbally in such case? Okay.
I mean, it would be more safer to go more limbally in all these sort of cases, just to see whether we can actually open the anterior, if there is an anterior, like if you're thinking it's an RD,
Correct.
I would
Even
want
then
to
you should
go
go
ahead
limbally.
and do the anterior PVR to be open, and that could possibly.
Different. Correct.
If the other eye doesn't have any peripheral retinal degenerations or anything, why
Correct.
would this? So then you start suspecting that
Correct.
I am dealing with something which is PFB. This patient has a cataract. That means it's at least 2 to 3 years of duration. The patient eye is 5 years of age. So it's already at 2 years or 1 or 2 years he has had this thing episode. And
Right.
now it has cataract.
Right.
Because if there is a fresh RT, then it requires at least 2 to 3 years for cataract to happen. So that is how we'll start thinking. And I think PFB has to be one diagnosis. We should always.
Correct.
In the interest of time, I think.
Yeah.
Sure.
So
Thank you so
thank you,
much.
Dr.